Okay, so Ionto won't be something, we're going to understand concepts and we're going to understand how to do it, but Ionto is not something that they do a lot in the clinic anymore. So this won't be something that will be on your practical, but it is something that you'll have to have understanding of. So we won't be asking you to do practical stuff for Ionto, just because it's not reimbursed clinically anymore. So very few clinics actually still use it. But you still need to know how to use it just in case you come to a place where it's used. Okay, so we're starting back on page 274. 274. 274. And we'll start with current characteristics dealing with direct current. So this will be the first time in all of our lecturing we're going to actually deal with something that is a direct current. Everything else we've dealt with was either AC or pulse current. This is true, this is going to be true DC current. So Ionto is true DC current. So it talks to us, it says current will flow under two conditions. One, when there's a source of energy creating electrical potential. We understand that. We have to have some type of generator. That's what the machines are. And two, when there's a pathway between the two potentials. So we need a pathway and we need a generator. We have that. It says in therapeutic E-stem, a charge transfer occurs between the biological tissue and the electrode interface. So remember we said E-stem is the flow of charged particles to an area to perform an activity. So we're flowing charged particles. Electrons flow converts to ionic flow within the body. So electrons, so the flow of electrons, which is electrical energy, once it's used via direct current, it's going to have ion characteristics underneath the skin. So it's going to be different underneath the skin. Hang on, let me see here. This is what I thought it was. It's the wrong thing. I thought we said Ionto. Okay, yeah, that's the wrong one. Yes. There we go, yeah. Okay. Yes, so underneath the skin, what's happening is we have flow of charged particles. So these are our electrodes that are connected to our body. Underneath, so flowing between this, we have current flowing from positive to negative. So current flows from positive to negative. And then we'll also have electron flow going that way. So we'll have the flow of charged electrons underneath the skin. Now, when this is happening, the electron movement is happening, it's also producing an effect in the tissue underneath it. When we're using a waveform that offers tissue effect. So this doesn't happen with AC because it's bidirectional, sinusoidal, so it doesn't build a charge underneath the skin. This doesn't happen with pulse current because it interrupts before the 1 second, which keeps it from building a charge under the skin. So this process only happens with the use of direct current. When current is applied to the skin, again, it flows from positive to negative, electron flow is happening, and then that's causing underneath the skin ionic flow. So underneath the skin, that's what you're seeing, is ion flow. So we're moving ions around. Specifically, the ones that we move around the most are sodium and chloride within the body. So those are things near the skin. We have a lot of sodium, and then it connects to different things, and that moves around in the body. Okay, it says ionic flow occurs because of the elementary law underlying electrophysics. It states that like charges will repel and unlike charges will attract. So opposites attract. So like things repel, opposites attract. Paula Abdul, circa 1989. Y'all killing me. Nobody? Nobody. Y'all never heard the song. Don't point at, he wasn't born in 89. It's an old song by Paula Abdul from 1989 called Opposites Attract. Y'all are kidding. No, God. I'll find it for you. We'll watch it after a break or something. Okay, so ion flow happens because like charges repel, opposites will attract. And that's what's happening under the skin when we're using direct current. When we introduce a direct current that has charged particles, it's going to push away like things or things that has the same charge as that electrode, and it's going to draw in things that have opposite charges of that electrode. So that's the concept. Like charges repel, opposites attract. Okay? So it says positive ions, which are called cations. So positive ions, which are called cations, are repelled from the positive electrode, which is called the anode, and they're going to move toward the cathode. So positive ions, which are called cations, are going to ultimately move from underneath that area of the skin toward the cathode. So cations will migrate towards the cathode. Anions, which are negative, are going to find their way migrating toward the anode underneath the skin. So we have like charges pushing stuff away, and it's drawing in opposite charges. It's like magnets. If you put two magnets together, they'll draw into each other. You turn them where the force fields are the same, they're going to repel each other away. You can't get them close enough. Same concept. It says at rest, the nerve is positively charged on the outside of the cell. We talked about that. Negatively charged on the inside. So it's going to have sodium inside, potassium on the outside. Potassium on the inside, sodium on the outside, excuse me. So sodium is on the outside. Sodium rushes in. So potassium inside, sodium outside. It's negative on the inside of the cell, positive on the outside. Okay? All right. Nerves will become hyperpolarized under the anode and more excitable under the cathode because of that. So because it's going to be positively charged, because of the way the cell is set up, under the anode, it's going to be more excitable. It's going to be less excitable underneath the anode, which is also positive, and it's going to be more excitable under the anode. So positive will draw toward negative in nerve signals. Okay. Although both anode and cathode are going to be required to have a complete circuit, the cathode is usually referred to as the active electrode, or the negative electrode is referred to as the active electrode, because nerve activation takes place more easily under this electrode. So when we're doing things that have charge base to them, so we hadn't had to deal with this in anything else because nothing else really had a charge. But when we're dealing with it, we normally want the cathode or the negative to be the one that's usually, I don't want to say it's over the site. It's the one where electrical energy will be drawn into first to be used underneath the skin because of that attraction. A negative electrode, positive nerve cell, they draw to each other. So up until now, we haven't done anything with charge, so it hasn't been relevant to right now. Everything we've used. So on the lead wires, when you're looking at them, you'll have a black and a red. Black is going to be your cathode, red is going to be your anode. So it's just like a battery in a car. Red is your anode, black is your cathode. So the black is the one that current will draw to easier. So because it's negative and it's going to draw toward the positively charged nerve cell. Remember, the cell is positive outside, negative inside. Okay? Okay. So, next thing it tells us is that underneath the skin, when we're using these charged particles, chemical reactions occur at the interface or where the electrode is making contact with the skin and causes transfer of charges. Sodium ions, which are already there, they're outside of the cell. Remember, so potassium in, sodium outside. Sodium, which are positively charged, will migrate toward the negative pole. So sodium are going toward the cathode. And they combine with water that's already underneath the skin and they form sodium hydroxide, NaOH, which is a base. This increases alkalinity, meaning it becomes more base-like under the skin near that area. Alkalinity. You hear a lot of folks talking about they drink alkaline water. Everything you need to eat needs to be alkaline, alkaline, alkaline. That deals a lot with pH. So pH is, normal pH is 7.0. So if we're dealing with normal pH, it's going to be 7.0. So, normal pH, 7.0. For something to be alkaline, it needs to have a pH greater than 7.0. And then for something to be acidic, it needs to have a pH less than 7.0. Alkalinity underneath the skin is not a bad thing. Acidity is. That's when stuff starts to break down and burn. Your stomach is full of stomach acids, which are acidic, which breaks down food. So acidic things are dangerous. Alkaline things aren't as bad. So it says the sodium hydroxide that's underneath the skin will promote liquefaction of proteins and softening of tissues. So it's helping to, it may help to break down things that are hardened or things that are not, things that are on the skin that are hard or things that are on the skin that have a protein-based shell. So we maybe would use these, you could use this theory with something like keloids or some of these other things that deal with hardening of the skin. We don't as much because they found things that are better and more useful than E-stem for those, but it could be theoretically used for that. Chlorine ions, which are in the skin as well, are going to, which are negatively charged, they're going to migrate toward the positive pole, forming hydrochloric acid under the skin, HCl, which is not a good thing. It's more acidic, promoting coagulation of proteins and hardening of the tissues. So Usually we don't want that. Both acids and bases can irritate skin, which is why it's common for there to be a small degree of erythema under the electrodes after using direct current. So there's a little bit of redness, you'll see that. Circulation is enhanced as the body attempts to neutralize changes in pH. Large charge accumulations when the current is too strong. Hang on. Oh yeah, large charge accumulations occur when a current is very strong. Meaning, instead of just having a small amount, we'll get large accumulations of it, and that's when we get skin breakdown. We're starting to get burns or breakdown underneath the skin when we have too much charge. Okay. Small accumulations are actually advantageous because they help with things like wound care and fracture healing. So we use direct current conceptually to deal with wound care, delivery of medication, or to deal with fracture healing. So we don't do fracture healing. It's done from a physician's office. You can get what's called a bone stimulator for fractures that are non-healing or that are healing very slow. They are prescribed by a physician specifically. We don't do anything with them, but patients may have one on and they'll tell you, I'm wearing a bone stimulator. So here's what it looks like.
I'm Dr. James Kennedy, East Texas Foot and Ankle Centers. I have a patient right here, and she has a contusion to the foot, a sprain in the foot, and I think we could possibly have a stress fracture here. So one of the things that we do here at East Texas Foot and Ankle Centers, we do bone stimulators. Bone stimulators work well in a certain population of patients. She's very lucky in the fact that she's very healthy, she's young, she should do well with a bone stimulator, but this is another treatment in our ammo belt to treat patients. What we do, we actually have this cord that's inserted to the electrical device. What it does is it has a magnet inside this area, and the current flows from one side to the other. Okay, as we know, we also have electrical current in the body. And what this does, it actually stimulates bone healing. So this is set, and it goes on for about 45 to 55 minutes, and it's a small electrical current that goes from one side to the other, and what that does, that heals bone. It's what we call a bone stimulator. So if a person has a non-union, malunion, if it's something that's very frustrating and painful, this is something over an extended period of time could help the person relieve some of their pain and heal the bone. So what I have, I've set this on her ankle, and I'm going to strap it down. I want it fairly tight. I want it what I call tight but loose. What that means is I want it to be loose enough to where she's not in any type of discomfort, but I want it tight enough to where she's not wobbling around while the device is on. So what you do is, it's fairly simple. You turn it on, just like we have it right here. And what we do is we push the button on, and then it should directly go on in just a few seconds. Okay? I have the little hourglass going right now. And now we have it working. And she will wear it for approximately 45 to 50 minutes. Thanks.
All right. So, get my button here. So that's called a bone stimulator. Again, they're not prescribed by therapy. We don't do any interventions with them. They are prescribed by the physicians. So if your patient has one, they'll be able to communicate that to you. If they do have one, they may be non-weight bearing, depending on what they need it for. And So they may be coming to therapy with that, using the device, but the device is not something they should be using while they're in therapy. They should be doing it at home under the prescription of the physician. Okay, so those are bone stimulators. So that's a type of direct current. So we don't use bone stimulators as a part of what we do. What we use for direct current related to E-stim is we use it for wound care for one, iontophoresis for the other one. Iontophoresis is our really big thing that we used previously it for, but again, they don't reimburse for iontophoresis, so a lot of places have stopped doing it. Like I've reached out to some friends who are still practicing at the moment and asked them, you know, hey, are y'all still using iontophoresis, or, you know, tell me about what devices you're using, and everybody's like, you know, every blue moon we may pick it up. So, but it's still important that you know it because it's something that's going to be relevant and it's still testable for the national board. So no matter what's happening clinically, the board says you need to know it, so we will teach it. All right, jump all the way over to 292. That's where we're headed now. Iontophoresis. This is where we're headed now. So the book tells us medications or drugs are introduced into the body by several different means. One is intraoral. So if you woke up this morning and you took some type of medication, whether it's a Tylenol or allergy medicine or a pain pill, or you swallowed a vitamin, whatever you took this morning, if you swallowed it with your mouth, it went the route of the enteral route, meaning it's going to pass through your digestive system and then be broken down in your digestive system and then dispersed to your body. That's how medications work. So you take them by mouth, they get into your digestive system, they're broken down in the stomach, and then they are dispersed throughout the body from that way there. That's called intraoral or swallowing. Parenteral is another way. Those are injections. That's when you go to the doctor, especially I used to go twice a year because my allergies would kick my behind. And I would have to get 2 shots in the hip. One was a steroid and one was an anti-inflammatory, trying to help bring down some of the swelling in my nasal passages so I could breathe again. That's parenteral. That's through an injection route. Or through passive absorption through the skin, transcutaneously. So if you've ever been on a cruise or you've ever seen people who smoke, they use transcutaneous routes. So you may see people, if you see people on the cruise, they'll have these patches all over their arms. You're like, what in the world kind of patch is that? It's a scopolamine patch, and it's there for nausea. So you'll see people with that, or you'll see smokers who have them, they use nicotine patches. I think Icy Hot does this. I think Shaq was doing an Icy Hot commercial for a transcutaneous patch, if I'm not mistaken. Anybody remember this? He's done 7,000. I know, don't you? Y'all are like, man, he's in every commercial on TV, it feels like. So Shaq was doing this thing.
Like you. I work hard every day. Back pain or not, because I get relief from the Icy Hot back patch.
Bigger than ordinary patches. First it's icy to dull the pain, then it gets hot. The Icy Hot back patch.
Count on it.
So that's transcutaneous. It's absorbing through the skin over time. Transcutaneous. So that's something, that's a way we deliver medicine to the body. And the other patches are just like that, like a scopolamine for nausea, or if they are on a nicotine patch, you'll see them on their back or on their side. There are other medicine patches. You'll be working with a patient who will have patches on sometimes. They'll have medication built into patches, and the doctor has prescribed, and they'll be wearing them. Make sure you don't do therapy over the patch. You'll have to remove it. If you're doing some type of intervention technique, massage, or if you're doing STEM, or if you're doing ultrasound, whatever it is, remove the patch first. Clean the area well, do your treatment, and then you can return the patch. so that everything is okay. Parental and transcutaneous are a little bit more beneficial because they will bypass the liver, which is referred to as hepatic circulation, thus avoiding a major site of potential degradation. It's just fancy words for saying medicine is broken down in your GI system by the hepatic juices released from your liver. So your liver is what's breaking down the medicine. It degrades part of it, means it breaks down some of it where it can't be used, and the parts that can be used are then distributed through your system. So if you're taking anything integral, that's what's happening. It gets into your GI system, your liver helps to break it down along with the enzymes in your stomach, and then it's delivered out to your body. Parental, either transcutaneous or through injection, will avoid the use of the liver, which means I'm getting more concentrated dose of med because I'm not getting broken down in the liver. Okay? Okay. So mechanisms of parental, again, injections, we talked about that. Transcutaneous, we just talked about that. Or the use of electrorepulsive iontophoresis or phonophoresis. So phonophoresis is delivering medication into the body using ultrasound. So you can do phonophoresis. So I don't know if we still do that a lot. Did y'all do that with Ms. John? Talked about it a little bit? Yeah, so it is something that's not done as much clinically as well. But phonophoresis is they'll take the medication and mix it in with the ultrasound gel, and you'll phonophorese or ultrasound it into the body. And it helps to use that waveform to help pulse it into the body. So instead of us using ultrasound, we're going to use E-stim to help get medication into the body. So we're using E-stim to help push medication into the body. Okay? So the next part talks about all the aspects with the skin. We're not going into deep understanding about the skin. Just know, let's see here. That first sentence right there in the paragraph there, the second sentence, we know that the skin has relatability to transcutaneous drug delivery. So just know that's all we need to go with that. So we're skipping all the way from the skin breakdown into electrical properties of skin, because that's kind of where we want to be. Page 294. Okay. So, with the skin, I guess I have to cover a little bit of it. So, with the skin, the outer layer is called the dermis. No, excuse me, the inner layer is called the dermis, and the outer layer is called the epidermis. So you have your dermis and your epidermis. I'm sure y'all already know this. Okay. Parts of the epidermis, called the stratum corneum, which is one of the outer parts of the epidermis, is one of the things that's highly resistant to electrical current. Remember, we said one of the main goals of E-stim is overcoming skin's impedance so that current will depolarize the nerve we're trying to depolarize. So the stratum corneum is putting a name on the layer that provides skin impedance, essentially. Stratum corneum. Okay? Yeah. It says over on the right-hand side, the high resistance of this layer to current is in part due to its lower water content. It's only about 20% water as compared to normal levels, which are about 70%. The charge the skin maintains in an electrical field is dependent on the pH. At a pH greater than 4, the skin maintains a negative charge when placed in an electrical field. And at a pH lower than 3, the skin is more positive. So, not as valuable to know that thing as it is to know the stratum corneum is the skin layer that provides resistance or impedance to current. So that's the main thing I want you to know from that. I don't really care about the pH parts. Just know the stratum corneum is the part that is resistant to skin impedance or providing skin impedance to current. Okay, so that leads us to the right-hand side, transcutaneous transport. It says, as described, the stratum corneum acts as a barrier to minimize water loss. It's also the principal barrier to transcutaneous drug delivery. Based on models, drugs can diffuse through the stratum corneum via either the transepidermal route or the transappendigeal route. So they can either go through the epidermis, transepidermis, or transappendigeal route. Transepidermal occurs within the intercellular domains of the skin itself. We don't do that a whole lot. Transappendigeal is usually the way we do more of, so the appendages of the skin, like hair cells and follicles and things like that, are the appendages, and those things allow for current to pass through easier. Okay? So it says down at the bottom, hair follicles and sweat ducts can act as diffusion shunts for iontophoresis drug diffusion. That's the main thing we want to get. So it's the appendages known as either our hair follicles or our sweat ducts that serve as the mechanism to get current and medication through the stratum corneum into the subdermal tissue. Okay. All right. So that's our goal. We're trying to use hair follicles or sweat ducts, which are all over your body. So it's not like you just find them in one spot. They're everywhere. So those appendages make it easier for us to get current and medication into the body in that area. Okay. 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 So that leads us to iontophoretic. We talked about passive drug delivery. We won't go back there. It says under that iontophoretic enhancement, iontophoresis is the use of a small amount of physiologically acceptable electrical current to deliver drugs into the body. That's his definition. Small amount of acceptable current that helps to deliver drugs through the transappendigeal route into the body. Okay. It says, with iontophoresis, an electrode of the same polarity as the charge of the drug drives the drug into the skin via electrostatic repulsion. Highlight that, start it. That's the main concept of what we're doing. We're going to use drugs that have a charge built into them, and we're going to use an electrode with the same charge, and we're going to use the concept that like things repel, and we're going to turn on current underneath that electrode, and it's going to repel or push the medication from the electrode into the body. It's repelling it into the body. through that transappengeal shunt. So we're pushing drugs into the body, or medication. I don't want to say drugs. Drugs sound so bad. We're pushing medication into the body, understanding its polarity or its charge, using the same charge electrode when we set up for E-stim. So we know that we have a positive charge electrode. We call that our anode. We have a negative charge function with our E-stim called the cathode. So based on the drug's polarity, we're going to push medication into the body using the same polarity of the drug as we do the electrode, that's over the ear. So that's the whole concept of what we're doing. So the book goes into some understanding on this. It says lidocaine, which is a cationic drug, meaning it's going to be it's going to be negatively charged. It's a cathode drug. It's a positive drug. So how do they call it? Yeah, cation. Excuse me. So it's a cation. I'm thinking about a cathode. It's a cation, meaning it's a positive. It has a positive charge. So lidocaine comes with a positive charge. If we want to get lidocaine, which is good for numbness or good for pain, into the body in a certain area, we would use a positive or an anode, so the positive electrode or the anode over that area, and we would have like charges repelling. Okay? So the goal is trying to push the drug into the body. Okay? All right. So there are a number of different, let's show you these. There are a number of different devices that you can use to do iontophoresis. Some of these are a little bit older. So this is probably the oldest device I remember. It was made by a company called Impy, and it's always blue. So if you're looking for it and you see a blue device, that's iontophoresis. These are still used clinically. A lot of places still use this old blue iontophoresis unit. It only has one channel, and it only sets up to do iontophoresis. It does not do anything else. So I can't set this up to do a treatment for pain or set this up to do a NIMS. It only functions as iontophoresis. Same manner, this is an iontophoresis device. Ooh, I thought I was about to drop. So same concept. This is iontophoresis here. It runs on a 9-volt battery. This is the electrode. You'll see that the electrode is different than any electrode that we've dealt with before, or the lead wire, excuse me. The lead wire is different. It does have a pin that's very similar to what we've used, but instead of it having pins here, it has clips, and the clips will click onto these electrodes that look like this. So it's a treatment electrode and a dispersive electrode. The clips will clip on here, and that's how current is introduced into the body using these iontophoresis pads, or these iontophoresis electrodes. So that's one. Here's the treatment one. So these are the two we would use. This is our old one. These are the two that we would use. So this is a dispersive, meaning it's just providing current and being out of the way. This is our active electrode here. And they both have these pins on the back where the electrode will connect to our device. So that's how we would get iontophoresis introduced. So that's a unit like that. That's this unit that you're seeing here. Sometimes you may clinically still see this unit here. So that's it there. And then the other unit that you'll see is called an Impy think it was bought out by Chattanooga, but it's called Hybresis. Used to be called Hybresis, Hybresis, but now they've changed the name to Ibresis. So the company Impy that developed this technology went out of business probably about 5-6 years ago, and Chattanooga bought it and changed the name from Hybresis to Ibresis. You can see there, ours is Hybresis, same thing. So our controller is by Impy, but it's the same concept. So it's more of a smaller base instead of those larger machines. It uses an all-in-one electrode, and it has a controller that goes with it that will describe how to use this in a few minutes. But these two go together. This controller clips onto the electrode like that, and then you have an all-in-one built-in dispersive and active electrode. So everything is all-in-one. And that's called Hybresis or Ibresis. Those are a type of electrodes. Okay? So how does this work? Let's jump down here, talk a little bit about it. It says hair follicles and sweat glands make up about 0.1% of surface area of the body and represent pores in the skin where things can enter. So where charge can be concentrated or things can enter the body. So 0.1% of the skin doesn't sound like a lot, but when you consider all of the skin, it is a pretty good amount. Okay. Over 296, evidence suggests that iontophoresis transcutaneously delivers drugs through the pores of the skin, and they account for the transappengeal shunt pathway. So that's why we like these hair follicles in our sweat glands, because they are the pores into the skin that allows for current delivery. Okay. Skip down to that paragraph underneath that, kind of the middle. There's a couple of lines here that are very important. It says the opening of the pores during iontophoresis is time dependent. That's important to know. As is the closing following the iontophoretic process. So using current allows these pathways to open and let medication be delivered into the skin, but at some point that pathway will close. You don't want your pathways open and letting things into your skin. Germs or a lot of other stuff can get in and can cause your body damage. So it's time dependent. The time required depends upon the duration of the current applied and the current density. Okay. It says, because of the augmented passive drug delivery process, iontophoretic applicators or electrodes should remain in place to maximize the amount of drug delivery transcutaneous. So after we do this treatment, we don't just snatch the electrodes off and throw them in the garbage and send the patient on their way. We will ask them to keep the electrodes on for a period of time, because it's going to enhance drug delivery passively even after we've done the iontophoresis device. Okay? So that's the goal. All right. So, instruments. Manufacturers of these devices have different clinical uses. Cystic fibrosis is one of the things that it helps to treat. Hydrosis is another, it's like sweating issues. A lot of times people will use iontophoresis if they have like really bad sweat issues, like they have sweaty hands and sweaty feet. You can buy a device that's designed specifically for that. It has a basin, and it will help with problems like hydrosis or like sweatiness of the hands and feet. I don't know if you've ever met somebody who had sweaty hands, shake their hands and it's always wet, like, ah, that's gross. So if you do meet somebody like that, you may want to recommend them iontophoresis. Yeah. So, yep. So this is kind of what it would look like here.
How to treat sweaty hands. Hi, my name is Dr. Dutton. I'm board certified laser dermatologist. Today we'll be talking about how to treat sweaty hands. There are several ways to treat sweaty hands, including the use of cream, surgery, Botox. But today we'll be discussing a special method called iontophoresis. So please stay tuned and I'll show you how it's done.
First of all, we use something called an iontophoresis machine. This is the one we prefer called an Idramet PS or Idramet GS. They're both made in Germany. Other iontophoresis machines include Fisher, but we prefer the Idramet because it's more user-friendly. Next, we use water. Often it's just tap water, but sometimes we can add a little bit of salt. The second step is to actually protect the cuticles and any cuts using just plain Vaseline. So this will protect the area and make the treatment entirely painless. So how this actually works is that it delivers ions or molecules into the sweat glands, which then actually stop sweating. So you can see it's just using tap water to begin with. This often suffices for most patients. If this doesn't work, we often add a teaspoon of salt. The timer is set usually between 10 to 15 minutes. You can see it's in German, but certainly this can be translated to English with using the menu. So we normally set it at around 10 milliamps for around 10 minutes in most patients. So the patient just sits there for 10 minutes and the iontophoresis does its job. The molecules are taken up by the sweat glands, and usually this gives us an average of about 3 to 5 days of sweat reduction. So you see we are slowly increasing the ampage all the way up to 10 milliamps, generally speaking. I'll put a little link in my description to see where you can buy these machines. These machines can be bought online. Like I said, it's the Idramet PS is a better one compared to the GS. The PS does not give you the electric shock compared to the GS system. Fisher also makes an excellent machine. If this doesn't work, we use something called glycopyrrolate. So this has to be prescribed by a pharmacist, and this is added to the solution. So we call it glycopyrrolate iontophoresis, and each of these are tailored to the patient themselves. So you can see the total kit here containing the glycopyrrolate, the solution, the Vaseline, timer, and of course the Idramet iontophoresis machine itself. So thanks for watching this short clip, and I'll provide more information on how to stop sweating in the next coming months. Please remember to subscribe for more information in regards to any laser treatments in the upcoming months as well. Thanks for that. Bye.
Okay. So, let me see here. So, that's, you know, and I know it doesn't sound like much to you if you don't have this problem. But people who have this problem would love to know that there are potential solutions out there where they don't have to keep suffering from this. It's not an issue that I have, but I could imagine that it would be something fun to deal with. You know, it can be cool to have. So that's something that they can use. You can do it for your hands and your feet. That same basin can be used for the foot. And it helps to immerse the foot inside of there, and it stops sweaty feet. You know, a lot of people like, my socks are always wet, it's pretty gross. I really need some help. So sweaty hands, sweaty feet, iontophoresis is something that we could use for that. So it is something that can be used for hydrosis issues, sweating issues. When you see hydrosis, just think sweating. The FDA is responsible for testing and regulating these devices. Of all devices that's used on humans in the United States. Iontophoresis kits have been classified by the FDA as Class 3 devices. They have not undergone clinical trials because they're marketed before 1976. They were cleared under the 510K pre-market approval rule and grandfathered in. So there's no guarantee that these devices that you see on the market are actually doing what they say they're doing. So you want to get good reviews and you want to buy quality products. Because they're grandfathered in, we don't know. They're not tested strategically all the time by the FDA. So just, make sure you tell your patients, or if you're talking to a patient, let them know, if they're asking you, they're like, hey, I'm looking to get this device because I want to try to stop this problem. Let them know, hey, read the reviews, make sure you're getting a quality device. Don't just buy anything. Don't buy the cheapest thing you find. Get quality. Okay. So, Ionto power sources. Current Ionto systems are either battery dependent, which means they are supplied by they're supplied by DC current, and they will produce DC current. So supply and production. They're supplied by DC and they'll produce DC. There are some form of DC. I think the big machine back here is one of the few that still has DC, but it's not for iontophoresis. It's for wound care. So it's not designed for this. These units are very specific. And it says it's either pre-programmed or programmable based on time, dosage, and what we're trying to accomplish. The drug applicator electrode may be selected as either the anode or the cathode. You're going to use it, not select it. It's going to just be an applicator. But you're going to use it based on whatever the polarity is of the drug you're using. So if the polarity of your drug is positive, then you're going to use the anode to treat because you're trying to repel away positive from positive. If the drug is negative, you want to use the cathode because you're trying to repel into the system. So the applicator is whatever you choose. The second electrode is only present to complete the electrical circuit. The patient is also incorporated. The circuit includes the drug delivery electrode, the patient, and then the non-treatment electrode. The waveform for iontophoresis is DC. So it's DC current that's going to go through the patient. Variations of impedance results in current intensities and voltage regulated Ionto devices demonstrating inter-subject variability. So everybody is not going to handle Ionto the same. So, yeah. Okay. All the time, iontophoresis devices are going to be constant current devices, and their job will be to adjust voltage based on impedance so that the current stays constant. In the event of poor contact of the electrode, manufacturers have incorporated auto shutdown. It'll stop it, but even if it's peeling up, it's still going to run the same. So you have to make sure the electrodes are well adhesed to the body. Okay, now iontophoresis is going to be calculated different than anything we've done so far. Yeah, so okay, yeah, that's good. Oh, that doesn't even have it in here. Yeah, so most of the electrodes can handle a current, a dosage current up to about 4 to 5 milliamps, which is good because the highest milliamps you're going to get on an actual DC device is like 3. No device well, you may get 4. Some devices will offer 4. I've never seen an iontophoresis device that offer an amplitude of 5 or greater. So the electrodes are designed to handle the current. Okay. And then again, active is in the treatment area, inactive is at a distal site. So iontophoresis is calculated different than anything we've done before. So far we've used things like frequency and amplitude, pulse width, time on, time off, or on time, off time, ramp. Those are things we're familiar with. Whereas iontophoresis is measured in dosages. Like you're taking dosages of medicine. When you go to the pharmacy, they give you medicine. They'll say take 2 milliliters, take 5 tablespoons, take 1 teaspoon of this. That's a dosage. Iontophoresis is treated like a dosage, just like that. The dosage is calculated as milliamp minutes. Milliamp minutes. Milliamp minutes. Which will deal with the intensity of the current or the amplitude of the current, and it can be up to 4 milliamps, times that by the duration that the current is going to be on. And that's going to be preset, not preset by the device, it's going to be usually communicated to you by the physical therapist. So they may say, I either want 40 milliamp minutes iontophoresed, or I want 80 milliamp minutes. So the two most common dosages dealing with iontophoresis for patients is either 40 milliamp minutes or 80 milliamp minutes. And it's a combination of time times amplitude. So it's going to be it's amplitude times time machine is on. So for me to get a 40 milliamp minute dose, I would either have to use 4 milliamps of current times that by 10 minutes. And that gives me a 40 milliamp minute dose. So if I were iontophoresin 40 milliamps, that's 40 milliamp minutes. 40 milliamp minutes. So 4 milliamps of direct current, and I'm going to do it over the area for 10 minutes. That's a 40 milliamp minute dosage. If I wanted an 80 milliamp minute dosage, I would have to do 4 milliamps of current times that by 20 minutes. If my patient, that's the objective, it's either to do 40 or 80. Now your patient may not be able to tolerate 4 milliamps of current, so you may have to adjust your amplitude to tolerate to their tolerance. But as amplitude goes down, time will automatically go up. So let's say this is my patient. The PT has requested that you do 40 milliamp minute dosage of iontophoresis over their biceps tendon because of biceps tendonitis. Okay, you turn it on, the patient can't tolerate no more than 1 milliamp of current. So even though you have a 40 milliamp minute dosage, you're going to have to do 1 milliamp of current for 40 minutes. Does that make sense? So whatever the patient can tolerate it's going to affect the time in which they're actually having the procedure done. There's no guarantee your patient is comfortable tolerating 44 milliamps of current. It is really high. 4 milliamps of DC current is pretty high. So most times people will ask for dosages, again, usually between 40 and 80 milliamp minutes. And so you're trying to figure out how to get that done. So even if that's the objective, 40 milliamp minutes, if they can tolerate 4 milliamps of current, then great. It's only going to take me 10 minutes. If they can't tolerate but 1 milliamp of current, then I'm going to tell them to have a seat and we're going to let this thing run until we get our 40 milliamp minutes. So it's going to take them 40 minutes. Hey, do you have somewhere to go? Because you're going to be here a while. So the machine is going to adjust itself based on patient tolerance. If they can't take but 2 milliamps of current, then they're going to not just be there for 10 minutes, they'll be there for 20 minutes. 2 times 2 is 4. So 20 milliamp minutes, 20 milliamp minutes is going to require 2 milliamps of current for 20 minutes. So iontophoresis is done in dosages. Just understand that. It's done in dosages. Done in dosages. Okay. Alrighty. Okay. Over on the right, it says down in the middle of the paragraph, the current amplitude range for all marketed iontophoresis devices is between 0 and 4 milliamps. Again, there's very few, if any, device that's going to be higher than 4 milliamp ability. So it won't have the ability to go higher than 4 milliamps. Okay. All right. So, all right. So we'll practice with that. All right. Let's get you a break here. Call it a lunch break. We'll come back about 12:10 to get you out about an hour, 20 minutes or so. All right. Call it a morning. Back at 12.